Good afternoon to all our webinar participants around the world. Welcome to yet another webinar brought to you by the Faculty of Dentistry, Msia University. You can call me my initial DJ, and I'm glad to be your moderator for today. Today, we are going to discuss on negligence in clinical practice, and we are indeed glad to be able to listen from Associate Prof. Dr. Ratnaswati Subramaniam for sharing today. Before we proceed into the sharing session, I would like to explain briefly how the question and answer would work. If you happen to have any questions for our speaker today, you are welcome to post the questions in the comment section in both YouTube or Facebook. I will assist to pick up, compile, and address the questions to our speakers. We'll try to answer all your questions that we received through the webinar, and if we do not have time, we'll try our best to reply to you after the webinar event. Before we start, allow me to briefly introduce Associate Prof. Dr. Ratnaswati Subramaniam. Associate Prof. Dr. Ratnaswati had been in clinical dental practice for more than 40 years. He is an active member of Malaysian Dental Association (MDA) and also Malaysian Private Dental Practitioners Association (MPDPA). In 2010, he joined Msia University as a lecturer in dental faculty, and since then he is teaching dental undergraduate students. His area of interest is in maxillofacial anatomy and orthodontics. Dr. Ratnaswati is a member of the Royal College of Surgeons of England in 1997. He is also a member of Royal College of Surgeons and Physicians of Glasgow in 2020. He has more than 20 years of teaching experience in undergraduate DDS degree program. Welcome to Associate Prof. Dr. Ratnaswati. The stage is now yours.
Thank you so much, Dr. Uy, for being my moderator to introduce myself as a speaker for the dental faculty at Msia University. Good afternoon, ladies and gentlemen, dentists, my fellow colleagues, and everyone over there. First and foremost, my topic for today's 50-minute talk is on negligence and its implication in dental practice. What I noticed that over the past 40 years, negligence and lawsuits are becoming more apparent since I started in 1980. What I want to stress here, especially for most practicing dentists, especially the junior ones who are going into private practice, that the patients are quite informative, and they are quite they know how much more than what they used to do back then in the 1980s. So they are more not trigger happy, lawyer happy to find faults, and with the internet they know the exact treatment procedures. What I will do is, this is the Faculty of Dentistry in Msia University, and this is where I work for the past 12 years. The definition of dental negligence occurs when a healthcare professional, that can be a medical doctor or a dental surgeon, or even your other healthcare workers, have failed to provide adequate care for the patient, that is you. This can include any instances involving incorrect or delayed or poor treatment quality that has led to further injury and suffering for the patient. The courts were using Boehm's rule or Boehm's test to see whether the dentist, what he has done, is it totally out of norm or is it wrongly done. And this was more on dental surgeons. They were more in this practice. It was more towards the dentist. So a group of dentists will try to establish what the dental surgeon has done is wrong or right. So this was the first one. It was established in 1957, and it held good till lately in 1995, where the next Rogers and Whitaker Rule came in. So this one is more patient centered, and every individual patient is taken as a single patient. So it is not in a group where the dentist, this is more patient centered. So this first claimed to be in the courts of the Australian High Court or the Supreme Court in New South Wales determination that a doctor has a duty to warn a patient of any material risk involved in a proposed treatment. So basically, the doctor who was treating this case, actually it was Whitaker, and she had seen an ophthalmologist and ophthalmic surgeon, and that what the doctor did, the surgery went very fine, and the outcome of that eye was super. But there was a claim that the good eye got some infection, and she went, that was called ophthalmic plegia. So that the patient lost the eyesight. So the patient sued the doctor, but the court found him wrong, overruled the precept that the doctor could not be found negligent in warning a patient if the doctor acted within the purview of common practice, even though other practitioners, that means according to Bolam, the first one, which was dentist-centered, and he was right, because whatever he did was absolutely right. But he did not warn the patient that the opposing to the contralateral eye, the good eye, it was not to be harmed. So to warn her of the possibility, so this possibility, the court found that it was approximately 1 in 14,000 that the sympathetic ophthalmia, a condition, could develop. So the trial court awarded damages was affirmed because in spite of Mrs. Whitaker expressed specific concern that her good eye not to be harmed. So this is the trend now. We are going to use this rule, the Whitaker versus Rogers. So mainly I want to highlight, especially to the younger dentist, the reasons to sue a dentist. This can be due to we do so many types of treatment, and we use so many types of drugs. So anesthesia complications that can arise because if the patient is allergic to lignocaine or mepivacaine or whatever local anesthetic, the patient also in the history, she will not tell that unless she has been to a dentist before. But if it was a new patient, she wouldn't know. So the failure to diagnose oral diseases and cancers, injuries to the oral nerves during surgeries. The next point is complications with bridges and crowns. Even a simple tooth extraction can land the dentist in problem if he has not followed the standards of normal care towards the patient. So in root canal treatment, the injuries may occur like chemical burns with sodium hypochlorite if the rubber dam is leaking, and also a breakage of instruments, of files, of reamers, and so there can be injuries. Complications from Novocaine is another local anesthetic, was reported in dental practice where patient had arrhythmias. So infections is another possible, very, very possible complication that if it is not been taken care, like in infective endocarditis, if a patient who has given a history of rheumatic heart fever, that one, if the history, if the parents can't give proper history, and if the infection which due to the extraction the causes by bacteremia, that means bacteria in the bloodstream, and usually the mitral valve gets damaged caused by this infection, the streptococci, any beta hemolytic streptococci. Usually it is streptococci or staphylococcus infections that damage the heart valves. And the proper consent, each treatment will have a specific consent. It doesn't mean that if there's an implied consent by the mere presence of the patient in the clinic and the patient signs it at the registration counter, that she allows the dentist to see her, or consent implied for consultation only. Even like cases like if the floor was wet after it has been mopped, if you don't use warning signages that there is a wet floor, if the patient slips and falls, they can sue you. So we as dentists, we have to take care that whatever injury the patient sustains in your practice is under negligence, because you have not taken care to make your practice as safe as possible to the patient. So your staffs are another cause of any litigation against your practice. That is the politeness, the how they greet the patient, and put up a smile. Answering of phone calls is the same. So they have to be well mannered and address, if you know the name of the patient, by his name, and be polite. That will take us far. And in the dental office, the specific consent for examination should be taken as consent for examination. You simply can't go and ask the patient to open the mouth and start putting your instruments into his mouth. You have to get the consent. Just tell him that I'm going to examine your tooth so that I can see what your complaint is. I can come to a diagnosis. So the clinical examination, the dentist and the staff must be with personal protection equipment, be professional in how we behave, and explain what you are doing. Whatever you are doing, please explain to the patient. And an absolute consent must be taken before you start each treatment. Post-treatment complaints will come from loose crowns and whatever complaint the patient says. Like regarding patients' complaint, like after delivering a denture, during the try-in, the patient has agreed verbally that the color is matching, is she finds that color suitable, the shade. So, and when it comes back for issuance of the denture, delivery of the denture, the patient will tell you that, no, I'm not happy with the color. So again, there will be a dispute between the dentist and the patient. So unless you want to prevent this complaint or this rudeness or whatever, when the patient tells you, when you're doing the try-in of your denture, of your waxed up dentures, please get a consent that the patient is happy with the shade that both of you have selected together, and use natural light, possible near the window with natural light, and get the patient or the next of kin to sign in your clinical records that the patient is happy with the shade. Okay, that will take you away from this complaint. So rudeness, that I can summarize the root causes of complaints as rudeness, delays, inattentiveness. I noticed that many of the young dentists, they they multitask. That means when they are talking to the patient or taking a history, if the phone rings, they look at the phone and try to see from whom the call is. And this is not good, because the patient needs full attention when you are listening or when the patient is talking to you. This may imply that you are not bothered, you are just listening to him but not showing any keenness in his complaints. So, direct eye contact with the patient is very, very important. And miscommunication, if there's any language barrier or the patient is not very well litigated, or educated, and there may be some miscommunication. So please be very careful and be very uh, attentive to what the patient is saying. Apathy, yes, please do not stay away from it. Do not show any color, skin color, or race, or religion, or whatever is that should be put aside. A patient is a patient by himself, and please treat him with respect. Precipitating factors can be adverse outcomes of treatment done earlier or the treatment that you are going to do. Isogenic injuries, that means the injury is caused by our negligence or accidental, where you are not have paid full attention when you're putting an incision or when you're suturing or when you're giving an injection. So it must be accepted that if mistakes are done, you have to write it down in the clinical record. So the principles of record keeping is contemporaneous. It has to be comprehensive. It should be attributable to that particular case, accurate and honest, legible. Usually doctors' writings are quite illegible, but make sure it is readable by anyone, and it should be complete with well dated and timed. And sick leave issuance, I've seen this very common in Malaysia, and it has happened that issuance of sick leave should be restricted to an extraction or a surgical extraction or a third molar removal or any fracture treatment, wiring, or whatever that has got a reason for you to give. You are in a best position to see whether the patient is really sick and he deserves medical leave. And this, in every sick leave, the doctor has to take to make sure that he has printed in small, in a legible typewritten, that this certificate is not valid for court purposes. That means in Malay, in our country, bahasa Malaysia, tidak sah untuk kegunaan mahkamah. That means the patient has got a court case to attend and he has come in for a scaling, just a normal scaling, a superficial scaling, and he requests you to give him sick leave so that he needn't attend court. And that is wrong. That is negligence. You see whether the case deserves a medical leave certificate. Okay? Don't simply issue medical sickness certificate unfit to work. So points to remember to avoid mishaps: always be truthful, never guarantee any treatment. Even you are the best surgeon and you say, no, it is 100%, it is safe. Do not say. Do not guarantee a treatment. If you make a 6-unit bridge, don't guarantee it. Although you know you have done the best, but any treatment cannot be guaranteed in the dental setting. Keep abreast with latest regulations of your own country council, dental councils. And please do keep in touch with the latest development by attending continual professional development courses. That is a must now. Yeah, you have to have accumulate certain points for you to be able to renew your annual practicing certificate. And practice mock BLS or CPR with your staffs, you and your staffs. You have to have practice at least, say, 6 months once. So what to do, how to call for the ambulance, where's the airway bag, where the emergency drugs kept, and check for the expiry date of drugs. So you are negligent if you prescribe drugs that are expired. And one more thing I want to remind dental practitioners is that if you're using a little bit of local anesthetic, do not keep half or 1/3 of the cartridge left behind. Do not keep it. Please put it into the yellow bin. And I've seen, and there are cases that have come up with the MDC, with the Malaysian Dental Council, and they have found doctors keeping their half cartridges in the drawers. I don't know whether they use it on another patient. So to prevent cross-infection, please do not use, these are all single-use cartridges, local anesthetic cartridges. And then the other point to remember is document whatever you do in the clinical practice. Please transfer it in words into your clinical notes. Ethics to be maintained, and do not hesitate if you are in doubt, please refer. You may think that why should I refer? I can manage this case, but you may not have that clinical acumen or that speciality to give the best for the patient. So our motto is not financial gain, but patient's safety is of utmost importance. Okay, make sure you have subscribed to medical indemnity insurance. And now from the year 2025, in our country, in Malaysia, every dentist, every practitioner should have indemnity insurance coverage. Guidelines in prescribing drugs. There is a legal and ethical obligation for all dentists to comply with contemporary standard of care. So if you are prescribing antibiotics, I've noticed that some GPs, they prescribe antibiotics for 3 days. That is not the norm. Any antibiotic is a course of minimum 5 to 7 days or more, depending on the severity of the infection. So please, this will make the bacteria become resistant to the antibiotic. So the next time you give amoxicillin, it might not help to take away the infection. So please stick to the ethical obligation that you have to is by prescribing for minimum for a mild infection, and prescribing antibiotics is again another, there are two schools of thoughts. Like if you prescribe for pulpitis, infection of the pulp, I think it is not legal or ethical to prescribe antibiotics for pulpitis unless there are the 5 signs of inflammation. That is, one is the pain, the swelling, the redness, the temperature rise, that is pyrexia, and of course loss of function. If there is a real infection where you can see it is purulent, there is pus, there is fever, then you're obligated to prescribe antibiotics. But if it's a small periapical abscess, I will not give any antibiotics. So the ethical use of drugs must be well documented. Ensure that the medical history is current and up to date. You have to update every time the patient comes to your practice. In the last 6 months, every 6 months you have to update. He may acquire certain illnesses that he had not had before. So you think, oh no, I've seen him 3 years ago, he is fine. No, you have to update, take a good medical history, and so that you won't fall into the trap of negligence. Follow evidence-based guidelines on prescribing in the country that you practice. I'm going to here just mention a few scenarios where dental negligence has gone to court, where the dentist has been found guilty. Scenario number one, extraction, which is a routinely done treatment in a dental clinic. You can call it bread and butter of dental clinics. If the infection requiring hospitalization, please do write a referral letter and send the patients early to hospitalize. They come with a huge, big swelling in the submental or submandibular area where you can see the patient has got difficulty in breathing. Don't keep him and try to give him 500 milligrams 3 times a day of amoxicillin and call him back after 1 week. No, that isn't. You must recognize. So there are dentists who have not taken this and just prescribed antibiotics, and there was no follow-up after 48 hours, and the patient have been hospitalized later on, and you have really been very neglected. You have neglected the patient. In severe nerve injury, that's what I'm going to come to that. Extractions, endodontic procedures. Endodontic procedures are the second most common alleged negligence was due to endodontic procedures. One of the above negligence claims due to endodontic procedures were general dentists, where the complications include instruments left in canals, that means fractured instruments, the nerve and sinus perforations, air embolism, life-threatening infections from the pulpal area, from the periapex. And when we use solutions for cleaning the canals, like hydrogen peroxide we used to use before, which was very, very strong chemical burns, will cause chemical burns and chemical injuries. And even with hypochlorite, sodium hypochlorite, you can cause chemical burns. So please, of this life-threatening infections, 7 were due to brain abscess. You'll be surprised that that simple chemical, and the face is all brownish in color. And the 4th is dental implants. In the dental implantology, when dental implants, we have got 10 implants were lost due to no osteointegration, where the treatment plan was alleged to be deficient and non-existent. So there was no proper treatment planning, post-operative infections, and of the 24 cases of negligence that we have been reported involving dental implants and surgery, the defendants were general dentists usually, and 1 was a periodontist. Substandard crown and bridge in prosthetics. We found that the margins of the crowns were not of up to standard, and there were lack of the cementation process, the crown prep process. Periodontal disease, there were 19 cases. Here, the defendant were general dentists. The majority of the cases, the x-rays were not routinely taken, and periodontal probings were rarely or never recorded. I think that is very, very true. we very rarely in private practice, they very rarely record the periodontal grading pockets. Orthodontics, of course, there were mishaps of negligence complaint about numerous teeth. The patient were undergoing resorption because of excessive use of force. And this usually happened with the general dentists who are not well trained. And the motto in orthodontics is continuous low forces. The forces must be continuous but very low. Don't use strong forces. Strong forces will cause teeth to get injuries to the tooth, where there'll be resorption to the roots. And the remaining 4 cases were TMJ injuries. So there are mishaps. If you go through, more general dentists were getting more implicated in negligence. Infections, I've told you about it, I've talked about it. And here the infections resulted in 4 fatalities leading up to brain abscesses or cavernous sinus thrombosis, which are very, very fatal. And 9 defendants were general dentists and 2 were oral surgeons. Dental injections are also, we think, after 40 years, for me, I think that giving a dental injection, either a block or infiltration, it may be intraligamental. It looks very simple, but for a new dentist, your inferior alveolar block, which is a blind technique, you should be very careful. That is what I just wanted to mention. On adverse drug interactions, of course, you get a good history, you will know that the patient is allergic to penicillins, so avoid penicillin. But some patients will tell you that I have taken amoxicillin before, but it is wise to consult the physician who has treated him with penicillin earlier. Please take the phone, call his family physician, talk to them and confirm with them if you're in doubt. Yeah, otherwise you can use alternatives. You can use macrolides like erythromycin or lincomycin or gentamicin, whatever macrolides, or cephalosporin. So you always have a choice. So I would like to thank Riskwise Dental Protection Limited UK, then my pathways in dental practice from the Faculty of General Dental Practitioners, Royal College of Surgeons, London, and the Malaysian Dental Council and the Ministry of Health, Malaysia. I would also like to mention my acknowledgement to Dr. Uy Dejuin, PhD, who helped me to be my moderator and to help me proceed with this presentation. And I also like to mention Justin Ng Yi Yuan, who helped me with my PowerPoints. Thank you so much. And now I'll pass the mic over to Dr. Uy.
Thank you, Dr. Ranasoti, for your sharing. I think essentially, being a clinicians, what we need to do is really to care for our patients and to have an empathy on our patients and so on and so forth. For our participants, webinar participants, if you have any questions, please feel free to ask the questions or by typing down on the chat, and I will then help to address that to Associate Prof. Dr. Ranasoti. And meanwhile, I think I have questions for Dr. Ranasoti.
Yes.
In case, right, while a dentist is actually performing a treatment and then he or she need to go to attend an emergency case, how do you think would that actually be a case of negligence? What's your opinion on
Yes,
this?
if it's a single practice and you're going to another practice,
Mm-hmm.
if you're already attending to a patient in your surgery, in your clinic, you cannot leave that patient alone with your nurse or someone by the side. You have to be there because you are responsible, and the ministry has already cautioned us that the PIC, the person in charge of the clinic, will be fully responsible for the patient in case of any injury or whatever it may be. You cannot go to another, unless you are in the same building, the same clinic, then you're going to go to another surgery to see a patient. Even then, you have to reassure your nurse that if in case anything, she can just call us. But if you're going to leave your practice premises and go to another practice while your patient is sitting on the chair, is not allowed. It is negligent.
Yeah, I can imagine. I mean, if I'm the patient and I'm sitting on the dental chair and then my dentist
Yeah.
actually went missing, then
Yeah, you will feel frightened.
Yeah, exactly.
Especially after giving a local anesthetic block, you shouldn't leave the patient's surroundings. You should be there always. And if you had to go to the next surgery, but your nurse must stay with the patient. The patient can never be left alone unattended. Thank you.
Yeah. So what happens if the dentist will need to go? I mean, to perform an emergency treatment on the patient. Do we still need to get a consent from the patient? I mean, it might not be possible to do so.
Yeah.
So
In a hospital setting, I think when the ambulance brings in the patient, our motto is to relieve the patient if the patient has got difficulty in breathing, or if there's bleeding, profuse bleeding. I think that's the only place where you don't get consent, because that is first aid. You have to attend to the bleeding, arrest the bleeding, restore his respiration, and then once he's stabilized, you have to get the consent for further management.
I see. Okay. Uh, I think we do not have any questions from our participants.
Okay.
I think I would like to thank Dr. Ranaswati for your sharing today, and I think we will end our
Yeah.
webinar today.
Dr. Uy, thank you so much. But
you.
I just want to give a short message before I leave, a take-home message to dentists who are practicing. My motto is, when you are not sure of the treatment plan or the treatment per se, do not hesitate. Just refer the patient to a specialist who is more knowledgeable in that case. So don't let your ego go. I mean, don't care about your ego. You know, he may be your classmate, but he has been trained as a specialist. You have to refer the patient for the best interest of the patient's care. He needs good treatment. So you can tell the patient, I'm not familiar with this treatment because you have got multiple root canals, and I'm not an endodontist. I would like to refer you to a specialist endodontist who will be more careful, and he will your treatment outcome will be much, much better. Okay, so please, when you are in doubt, please refer. Thank you.
Thank you, Dr. Ranaswati.
Yeah.
I think we all actually get to know your message, right? When in doubt, do refer. Essentially, dental practice is actually a teamwork, and we actually work together to improve the well-being of our patients. And so I think that will be the end for our sharing today. Thank you very much, everyone, for being with us today, and we look forward to meeting you in our next webinar series. Thank you very much. Yeah.
Thank you.
Everyone.
Thank you. And I would like to mention again, thank you so much, Masa University.
Thank you. Yeah. Bye-bye.